Hey guys, how are you? I'm going to make a um, simplified video of pathophysiology of diabetes, type 2 diabetes mellitus. Okay, I'll have another video for type 1 diabetes mellitus. So their introduction would be kind of similar, but nevertheless, listen to it twice because diabetes, right? You will get a lot of questions on diabetes. So just remember that diabetes mellitus, it's sweet, right? There is also diabetes insipidus. We're talking about diabetes mellitus right now. Is a condition which is characterized by lack of insulin-mediated blood glucose control. Lack of it. There is no proper insulin-mediated blood glucose control because insulin is the hormone that is supposed to be controlling glucose, right? And so what happens? If there is no control of glucose, there is an elevation of blood glucose levels. You know that as hyperglycemia, right? Hyperglycemia, and that happens over a long period of time. And it's very important. And why is it very important? Because 1 in 10 U.S. citizens has one or another form of diabetes. 1 in 10% of this country has one or another form of diabetes, okay? And there are many. Type 2, which I'm going to be going over right now, is the most common. 90% of, some say even more, 90% of diabetes is type 2 diabetes, okay? There is also type 1, another video, gestational, and some other types that are less common, okay? So basically, every single one of us has a family, friends, or sees patients with this disease, okay? So very, very, very important, right? Obviously. So what you do need to know, the most important thing is that regardless of their pathophysiology, which is different. So all different types of diabetes have a different pathophysiology. What does it mean? How you get there to these problems with insulin is different, okay? But what unites them is almost identical complications over the period of longer duration, 5 to 10 years, okay? What are those? Damages to the heart, damages to the brain, and damages to the, what we call peripheral vasculature, myocardial infarction, stroke, etc. Okay, that's diabetes mellitus, very common cause of worsening of those conditions. Okay, damages. Now, what else? Damages to kidney, damages to the eye, damages to the vasculature of the eye, the retina, the lens of the eye, the nervous system. That's all diabetes. Doesn't matter which one, okay? And these damages are, it really doesn't matter which one, which type of diabetes you're talking about. All these damages are simply due to long-standing and poorly controlled diabetes, mainly poorly controlled hyperglycemia, because all diabetes types eventually result in hyperglycemia, right? There is and this is over the period of 5 to 10 years. Now, there is a thing called hyperosmotic, hyperglycemic, non-ketotic state, which is abbreviated as HHNS. Sometimes you see it as HNS, okay? Different abbreviations, okay? But it's a very, very dangerous and feared complication that's pretty much unique to type 2 diabetes, pretty much. Okay, there are exceptions, but pretty much, okay? Now, what do we see? Well, what is normal blood sugar? Less than 100. You would all agree with me, right? Well, what if your patient comes into you and has a blood sugar of more than 600 milligrams per deciliter? Then you do suspect hyperosmotic, hyperglycemic, non-ketotic state. Very dangerous. All right, now let me talk about the pathophysiology of type 2 diabetes mellitus, okay? So a very, very simplistic, simplified version, okay? Obviously, you know already from your previous studies that all body cells use glucose to generate energy, and that this glucose is therefore an important fuel for most of our bodily functions, right? Okay, now, where do you get glucose? Glucose is obviously provided to those cells from the vasculature that surrounds them, namely the very, very small blood vessels known as capillaries. So the capillaries that bathe these cells or tissues provide that glucose. Okay, So if that blood level, so in the capillaries or in the rest of the blood, drops too low, what will happen to the patient? The patient falls into a coma. All right. Now, what happens if the blood glucose is too high? I've already just gone over this. Serious, very serious, acute, namely for type 2 diabetes, hyperosmotic, hyperglycemic, non-ketotic state, and chronically, all those damages that I mentioned below, the damage to the vasculature of the heart, brain, peripheral vasculature, the kidneys, the retina, the nervous system, the lens, etc. Right? Those are all seen. So it's really important. It's really important that glucose in blood is very, very tightly regulated and kept within very, very narrow limits. Okay, very, very narrow limits, constant. Okay, very tightly regulated, very narrow limits. Okay, now that's glucose. Let me move on to insulin. How do you spell insulin? I-N with an I, insulin. What does it do? It drives glucose into the cells, okay? So insulin drives glucose into the cells. That's the introduction to insulin. That's the introduction that you need to know, is the fact that you need to know, okay? So what is insulin? It's the main regulator of glucose in the body. Okay? It's an endocrine hormone. And you know that endocrine hormone means that insulin is released from wherever it is. We know that it's the beta cells of the pancreas, and then dumped directly into blood in response to glucose level elevation. As soon as glucose goes up, beta cells of the pancreas sense it and start releasing insulin, this endocrine hormone, directly into blood. Okay. By the way, the name insulin comes from the Latin word called insula, which is an island. Okay. And why is it an island? What's up with the island is because the beta cells of the pancreas are found in little islands, which are known in pancreas. Beta cells of the pancreas are found in little structures in the pancreas, which we call islets of Langerhans. Okay, after the guy who discovered it. By the way, never mind. The guy was a medical student in Berlin, in Germany. Very interesting, right? Back then, things used to happen. You know? All right. So these islets of Langerhans, beta cells, beta. So once again, beta cells are found in the islets of Langerhans, and these islets of Langerhans are the endocrine portion of the pancreas. Obviously, there's also an exocrine, which is irrelevant so far in this particular presentation. Okay. Now, as you imagine, because these islets of Langerhans have to be so sensitive to glucose levels, there is a very, very good perfusion of islets of Langerhans, because they need to know, like every second of our waking life, do we have enough glucose in the body or not? Because you don't want to get into a coma and you don't want to start damaging yourself, right? So, and it is true, islets of Langerhans receive a whopping 1/5 of all the blood going to the pancreas, but in reality, they only constitute about 1%, 1 to 2% of the whole. Okay, so a very small part gets 1/5 of the blood. Okay, now how do we know that this is true? Because when we measure the level of insulin response to glucose in blood, we see it peak at 2 to 4 minutes after arterial glucose level rises, okay, usually due to ingestion of food. Okay, now precise pathophysiology of type 2 diabetes hasn't been really clarified, but what we do know now is that it's a disorder that we characterize by 3 things. Okay, and I'll go over those 3 things, but in general, what you want to know is that it's a failure of pancreatic beta cells to raise insulin levels due to a combination of 1, insulin resistance, 2, deficiency of insulin, and number 3, high glucagon level. Okay, so 3 things. Let me go over them again in detail. Number 1, insulin resistance, which is the main underlying principle, by the way. Okay, main underlying principle in the pathophysiology of type 2 diabetes mellitus. There is a relatively speaking, deficiency of insulin secretion by the pancreas, which I'll tell you is relative within boundaries. It may be a complete deficiency of insulin secretion toward the end, and high glucagon level. Okay, this is something that has been added to your knowledge bank relatively recently. Okay, there are a few other things, but that would be something you may study once you get further down in your education. This is not NCLEX relevant, I'll tell you right away. Okay, so insulin resistance. What does the word resistance mean? So I'll try to make it applicable to daily life. Okay, let's say a mother calls her little kid. Okay, the kid is like 3 years old. Johnny, come here. Food is ready. Okay, Johnny comes right away. No problem. Johnny's 3 years old. Now Johnny is 6 years old, playing video game. Johnny, come here. Johnny's not coming. Johnny, come here. Johnny's not coming. Johnny, come here. Johnny's coming. Johnny's going to be on the way. Okay, that's increased resistance to mom call. Okay, because Johnny's busy playing video games. Okay, which is true. Okay, he is busy. Okay, now Johnny's 10 years old. Johnny, come here. Johnny, come here. Mom can be shouting the whole day, right? I mean, obviously I'm kidding, but you understand that here we have in this case, if there is a Johnny, then what would the problem be? The mom is calling Johnny. Johnny's not responding. When mom raises her voice or gives some other incentive, then Johnny would go to mom. Okay, insulin resistance was initially actually called insulin insensitivity. That means the body wouldn't really respond to insulin. So resistance to what? To insulin. Insulin says, "All right, glucose, go into the cell." And the cell says, I don't understand you. What do you mean? And insulin says, "Hey, I'm a hormone. I want the glucose to go into the cell." The cells just don't care. That's insulin resistance. Okay, so insulin's ability to move sugar, glucose, from the blood into the cells is limited because of multiple problems with this insulin receptor. Remember, I went over receptor. Receptor is the protein on the surface of the cell membrane that can receive that information, that can actually receive insulin and do something about it, right? So it can happen, and so multiple abnormalities happen at that level, and basically insulin doesn't get what it wants, what it's supposed to do. Body does not get what it wants by secreting insulin. So initially, this insulin resistance can be compensated for. What do beta cells do? They are like, okay, so we make insulin, no one listens to it. We make insulin, no one listens to it. Fine, I'll make more of it. And from your pathophysiology week 1, how can you make more of something? Well, you become bigger. That's bigger in size. That's called hypertrophy. Or you become bigger in number. That's called hyperplasia. So what happens to beta cells? Both hypertrophy and hyperplasia, and beta cells pump out more and more insulin, trying to bring that elevated blood glucose level down, right? Because why do you need to release insulin? You want to bring down that blood glucose level. That's the whole purpose. All right, so that's the first step in the development of type 2 diabetes. Okay, resistance, and beta cells try to kind of make up for it by hyperplasia and hypertrophy. Okay, now why is it that our cells become insensitive or resistant to insulin? And there are multiple factors. Genetics do play a role. People underestimate how important genetics are in type 2 diabetes. Okay, But environment matters too. High calorie intake, a lot of food, eating a lot of food. What happens if you eat a lot of food? You gain weight. Eat a lot of food, gain weight. Eat a lot of food, gain weight. What happens after you gain weight? Other problems. Okay, so all of these problems associated with high calorie intake, okay, do matter. What else matters? Sedentary lifestyle. Believe it or not, obesity decreases expression of glucose receptors on the cells, meaning that when someone is obese, that person's receptors that actually take glucose and bring it into the cells in muscles and fat tissue, for example, are actually found less on the cell membrane than in a non-obese person. And quite the opposite of that. If someone works out, exercises, does not have a sedentary lifestyle, those receptors are sent to the cell membrane on fat and adipose tissue and muscle tissues, even without insulin. Can you believe it? So genetics and environmental factors matter a lot. Okay. Now, let me move on to the second point. What was the second point? A relative deficiency of insulin secretion by the pancreas. We just spoke about number one, insulin resistance as the main underlying principle in the pathophysiology, right? So in the second point, I want to tell you that patients with type 2 diabetes mellitus would not even develop diabetes if they just could keep on becoming bigger, hypertrophy, and increasing number hyperplasia. They would just make enough insulin to compensate for the resistance, right? Just lifelong, okay? Unfortunately, this insulin secreting capacity decreases over time. Why? Another term that you studied during week 1, beta cells atrophy. Atrophy, that means what? Shrink. Hypertrophy, opposite of that is atrophy, okay? And this islets of Langerhans and pancreas show other signs of damage as well, okay? And thus, because they atrophy, because there are other signs of damage, this machinery, the beta cell insulin secreting machinery, can no longer compensate for that very high demand of insulin. Okay, and I'll go one step further to say that while most patients, kind of get progressively worse, and it depends. Some get just a little bit worse, some get further down the road worse. Levels of insulin resistance kind of like keep on increasing, right? There is a certain segment of the type 2 diabetes patients that don't make insulin at all. They're essentially, they make zero insulin. Okay, most patients do make some insulin regardless, even if we have to give them insulin because nothing else works, okay? They do make some insulin. In type 2 diabetes, most patients do make some amount of insulin. Just a very small segment of the population does not make any, okay? And the final point is that type 2 diabetic patients also have very high levels of glucagon. How do you spell glucagon? GLU, as in glucose. Glucagon, what does it do? It's the anti-insulin hormone, also produced in the islets of Langerhans, in the alpha cells, as you studied, right? It's anti-insulin hormone, alpha cells, anti-insulin. And what does it do? It releases glucose that is stored in the body. Okay, it releases it. Okay, so there is normally in a healthy patient a normal interrelationship. You either have insulin going, like doing its best to drive all that glucose in blood that's elevated into the cells, or you have glucagon saying, dude, I'm starving, I need more, I may potentially fall into a coma. Let's raise that blood glucose, right? So normal interrelationship between insulin and glucagon in these patients is disordered, okay? And so you have abnormally high levels of glucagon secretion, and therefore, what does glucagon do? It releases more glucose into blood, and therefore hyperglycemia follows. Okay, glucagon increases, hyperglycemia. That's it for pathophysiology of type 2 diabetes mellitus. What I want you to remember, most important final point, is that all types of diabetes present as problems with insulin, but the complications of diabetes are due to hyperglycemia. All right, that would be it. Thank you very much.